But we have Dr. Lewis, Dr. Griggs, and myself to answer any questions you have for the next 40 minutes or so. What we want to do is make sure that you have a microphone so everyone can hear the question, and then we'll try to answer. And then one question that I had that someone asked is, how do you join the study version?
So you contact Patty Smith in Rochester. I think her contact information is on the PBA website under the hip-hop dichlorphenamide trial. I've seen it. It's a good. The PBA website's terrific. They work very hard on having it there. I would also say I've given out my business cards. I think I have more in my room. We'll be going back up there as soon as these questions are over. If you want to hit me up for the card, I can make sure you have my card to email me. That would be the easiest way to get to me. If I run out of cards, I'll just write it down for you. And Jake knows how. He sends me something about twice a week requested from one of you.
Yeah. The other thing is, if you have questions, there is this PPA Ask the Experts, and I screen all of those. And if there are questions directed to one or another expert, you can say, attention, Dr. Griggs, attention, Dr. Cannon, or whoever is, on the advisory board, and I forward it to them, and hopefully they have time to respond. And if we don't respond, we just ask again, and eventually the question will be answered. We try to do it in a timely way.
Yes, and if you have tried to contact me and I haven't responded, just resend it. I'm getting fewer emails now, but when I was president of the Academy, I was getting over 1,000 emails a day. And so I spent between 12 and 14 hours a day handling emails, but now it's less, but it's still over 500. So occasionally you might lose one of those or mark it unread and then forget to get back to it. So just try to be patient and understanding, because we do get lots of contact. But periodic paralysis is our major interest, so that I am interested in the issues.
So let's start with questions. Let's start with someone in the back, I guess, with Lois there. Sorry. Not Lois.
Dr. Griggs, you mentioned exercise as a trigger. You mentioned exercise as a trigger, but only whenever you rest first. Is that correct? And the other part of it is, does that relate only to hypopigmentation?
Yeah, so I think both, or actually all three of the genetically defined periodic paralyses seem to be triggered if somebody exercises, particularly they do unaccustomed or strenuous exercise, when they don't tend to get weak immediately during that exercise, but anywhere from a few minutes to an hour or two after the exercise, the patients will get weak. Sometimes if they were kicking a ball or something like that, they'll get weakness just in that muscle. Or if they're doing something strenuous with one arm, it'll be just in that muscle. I don't, as I said during my talk, I don't think this is a reason not to exercise, but I think it is just a fact of life that if you do too strenuous exercise, when you stop, you get weak. This is why one of the reasons I advise modest exercise. Now, Jake never listens to me because he's a tough customer anyway. He overdoes it, but he seems to tolerate it fairly well, so he's built up to a pretty good level of physical fitness.
The reason for my question, Dr. Griggs, is that I do have weakness with exercise as I'm exercising, so I wondered if that excludes me in some way from.
I don't think so. But you can, if you're very weak, injure muscles that are weak, so you need to be careful. Just the people in the weightlifting field say no pain, no gain. And I think that is absolutely wrong for muscle patients. I mean, if you have pain, then you cannot and should not be doing that exercise.
I mean, I would just add that, exercise can be defined in many different ways. Just walking down the hallway here is exercise. You need to begin slow. And people who say, oh, I got to exercise, and you end up, trying to, run 5 miles when you've never run around the block, you're going to be weak. It's going to hurt. You're not going to like it. So you can't just jump in, you gotta start low and slow. Regimen, routine is key. You can't just, this week I'm gonna exercise and then not do anything for the next week and a half and then go back to it. You gotta do something every day.
I have a question. I have the unpublished variant hypo. I'm allergic to sulfa. I'm on no meds. I just got it in September. I got my blood work back from Dr. I don't take potassium. I have changed my eating to a traditional diet, which is recommended from the Weston A. Price Foundation, which is whole food. There's no, I don't use any processing at all. I use the grain-fed meat, grass-fed meat, I'm sorry, not grain. And I use raw milk that's low pasteurized. I have the farm fresh eggs. So I do all of that. That has changed my, now I don't even know what episode it is, you defined it, but from being totally weak and laid out to about 22 times a month down to 4 times a month. I am still weak at times, but I can sit through and work on the computer and do my job. But from what I've understood from you that you said, is that without any treatment, my weakness could develop into permanent weakness or debilitating muscles. So I don't know what to do. I mean, I'm like, okay, I don't know what to do now.
So I would say it's probably a bad idea for me to try to sit here and interview you and take a medical history and make a diagnosis and recommend treatment without examining you or knowing what the mutation is. I should just say that the genetic diagnosis of periodic paralysis, that I'm sure Dr. Lehman-Horn told you, is challenging. If there are no mutations, and if you have one of those, it's easy for us to say that you have a mutation and that you have periodic paralysis. If you do not have one of those mutations, often patients have what are termed polymorphisms in the gene. Each of us have, every one of us in the room, all of us, those with and those without periodic paralysis, have thousands of polymorphisms that are not causing diseases. So if you find a polymorphism in a gene, that does not necessarily mean that it's causing disease. And this created enormous confusion when we started doing genetic diagnosis. So it's a very tricky thing to show that a new unreported mutation is pathogenic. What you have to do is look and see, does it occur in 500 normals? Does it run in the family with the disease? And then you have to do about a $50,000 series of experiments to define that abnormality is producing an abnormality that can cause periodic paralysis in an animal model. Very expensive and tricky to do.
What changes what qualifies as exercise? Is it a natural progression of the condition to be young and for weakness to be brought on after large exercise, and then as you age or have uncontrolled attacks or something, for regular daily activities to become like exercise? Like you said, walking down the hall is exercise. When I was a child, I would exercise very, very hard and fully, sometimes for an hour, and then when I would rest after, I would collapse. Whereas now it seems like daily tasks like straightening my hair can set off my arm. Is that a progression of it? Is it?
Again, it may just be part and parcel of the disease process. As we've talked about, there seems to be progressive muscle damage with attacks. And so the muscles get weaker and replaced by connective tissue and fibrosis so that you can't do as much. The question is, can we prevent that earlier on? what qualifies, I mean, as Dr. Grigg said, the no pain, no gain is a real bad idea. If it's painful, you don't do it, because it hurts the muscle disease patient. But what qualifies as exercise for you is going to be different than what qualifies as exercise for a more wheelchair-bound patient, or somebody who's very active in physical things like karate.
So let me just say, I'm a nut about physical exercise. I run marathons myself, so I really, really think exercise is good. It's good for your heart, good for your lungs, good for your bones, good for everything. And probably good for your muscles, so that I think that the trick from my point of view is to get with the right specialist and get your strength better. Because I think we can improve the strength and prevent the weakness with appropriate treatment in most, if not all, patients. I've said all patients, but that's a bit maybe too optimistic. But I've yet to see patients we haven't been able to improve, so I'm intent on doing that.
I just wanted to make one more comment about this whole is exercise good, is exercise bad issue, because it probably sounds sort of like, what am I supposed to do? That in some ways we're not giving you, the guidance seems confusing. So let me try to explain it, what we think is probably going on inside the cells, in the muscle cells, and there's other situations we face some of the same issues in epilepsy or in stroke. What we imagine is going on in these situations is when you're having an attack, you're having a lot of sodium or calcium coming in through the channel that's not working well, and as a result of either sodium or calcium coming in, your cell starts running out of energy, and you get more sodium and calcium coming in. And in fact, this is probably why so many of you, when you're trying to reach a diagnosis, people are also considering mitochondrial diseases, because those don't have a problem with the sodium or calcium channels, but they have a problem with the cell's energy. And in all three, you're having this final common pathway of sodium and calcium coming in and the cell running out of energy. So to get back to the exercise issue, what happens is if your cells don't use any energy at all and don't have any sodium or calcium coming in, your body interprets that as, well, this muscle isn't needed, and it doesn't produce enough muscle to keep up the strength of the muscle. But on the other hand, if you have too much, you start damaging the cell. So the goal is to be in that in-between period, and the way that you can clinically test that, get a sense of that, is if you're getting attacks, if you're getting too much fatigue, that is getting to the too much point, but there's clearly a too little point, and you want to get as close towards that. You want to do as much as you can without having the problems, as Dr. Grigg said, of the pain. Here, pain is not gain. Here, pain is damage.
I have a question that has to do with hypersensitivity to environment. My daughter, Miriam, has almost incredible sensitivity to popcorn, peanuts, and various other environmental issues. And I'm wondering if this hypersensitivity is part of this syndrome, or is it a separate issue? Because I've noticed other hypokalemic folks also have what I consider extreme hypersensitivity to environmental things.
I'm gonna let Dr. Siegel comment in a second. I think that sometimes we like to attribute every single symptom. Oh, my stomach felt funny. Oh, I had a headache. Oh, I had a palpitation. Some of these very well may be part of periodic paralysis, but they very well may not be. And it's very hard to tease that apart. And it's very easy for someone to look at a textbook and not see those things listed and say, no, that's not part of it. And it's very important to keep an open mind that maybe it is part of it, but you kind of need to bear that out by properly characterizing the disorder. So it's going to be really difficult to say whether it is or is not part of it.
So first of all, when people speak of hypersensitivity, we should distinguish two different types, which are probably very different. One is hypersensitivity to sensory stimuli, such as noise or things like that. And that may in fact be related, to one of the forms of hypokalemic periodic paralysis for which the gene has not been found yet. Another is sensitivity to foods in an allergic sort of way, and not necessarily the classic IgE allergic. It may be some of the other types of food sensitivities that have to do with IgG instead of IgE. And in some of those food situations, you can have digestive problems, you can have reactions to the food, and we know from a lot of situations that digestive problems of that sort can cause loss of potassium in your digestive tract, and that can trigger episodes as a result of lowering potassium. And there's definitely an increased incidence of digestive problems reported in people who have a diagnosis of hypokalemic periodic paralysis. It may be that those are people who are just coming to attention more than others because they're more likely to have the potassium going low. It's conceivable that there's actually some issue in which it's actually caused by the gene, although nobody's found such a thing. And so these are all sorts of things we're trying to puzzle out too. But when you say hypersensitivity, you should make it clear if it's an allergic type of or a food sensitivity, or if it's feeling barraged by things like sound.
Well, one other complete non sequitur, just because you're sitting next to Ann there. Ann mentioned a great point the other day to me, that when you're coming out of an attack, sometimes you're feeling so bad, and then you come out of it and you're like, wow, I feel better. And then you try to go ahead and completely overdo it because you're better. And that sometimes knocks you right back down. So I think it's a valid point for some people that if you get out of the attack, to take it easy and kind of gradually get back into things. Anyway, okay, I just want to interrupt
Dr.
there.
Siegel, we were having some difficulty hearing you back here.
Well, for the next one, we'll hold it close to the...
Sorry.
I've always been a great believer in exercise, and I've done as much as I can over the years. Oddly now, I'm getting a little older, obviously, my legs have about 1% of their strength while I'm in the wheelchair, and yet my arms still are almost as strong as they always were. I still keep working out with dumbbells, but it seems, and I think quite a few other people have talked about this in the past, that it seems the great weakness really seems to hit the quads more than anything. Is there any rational explanation for that?
So this is a really important issue in all of muscle disease, because one of the things that we know is that there are some diseases that affect the face, there's some that spare the face muscles, there's some that affect the muscles of the proximal legs, there's some that affect the distal. And so you have floppy feet, and perfectly normal thighs. We do not understand that. One of the biggest unanswered issues in muscle disease. It does tell us something very important, however, and that is that the gene abnormality is necessary for the disease, but not sufficient to cause the disease. This is true of all muscle diseases, because in virtually any muscle disease, there are muscles that are severely involved and muscles that are totally normal. They all have the same gene abnormality. So we know that there are factors that are not the same gene factors that determine which muscle gets weak. So you're saying your quads are weak, your arms are normal. What is it that makes that happen? We are trying to understand that. I personally think that's the key, going to be the key to treatment. Because if you think about it, in periodic paralysis, it's a disease where patients are relatively good most of the time and very, very bad occasionally. What is it that causes that? I think that it's a combination of shifts in potassium caused by diet, exercise, stress, and you probably haven't found all the factors. But in fact, it suggests to me that we can figure out the right combination of treatments. We should be able to prevent the attacks and prevent the weakness. And I said repeatedly now this morning, I think that so far, most patients we've been able to improve their strength with appropriate management by modifying not the gene, but the triggering and other factors.
Let's take someone just from the front. So.
I know a number of person that trains, their muscle strengthens. But for me, when I train, the more I train, the weaker I get. And then I have to, I need a resting period of a month or two to start to train again. And then I can't train as much. I need a longer, a shorter period before I start to get weak. And then a longer period to recuperate. So is there something I could do to be able to train longer without getting weak?
I think that a lot of times there are symptoms that are unique to an individual, and sometimes sometimes there's symptoms that you say, okay, I'm weak because I have periodic paralysis, and we say, okay, well, take potassium, take acetazolamide, and that weakness will improve. And then other times there's kind of symptoms within, okay, I have periodic paralysis, but I'm still not improving. That starts to be, there's no magic bullet. It's going to be a kind of a unique, talk to your doctor kind of thing and experiment with tweaking, optimizing different medicines. I don't know if, Steve, if you have... Okay.
So this is one reason we have physical therapists that work with us and with our patients. So I think in general we can find the combination that is effective.
My name is Nikki, and thank you so much for answering my question. I'm a little nervous. And my question is regarding my 80-year-old daughter, who is now having 2 attacks a week, and I'm so worried about her future and the muscle damage. Unlike everybody else in the room that runs into a doctor that doesn't know how to treat you or give you medication or what they're dealing with. I'm here with her. She's running around. She's doing great today. She just takes potassium as she has an attack. We tried Dimax, doesn't work. What do you suggest for me to give her the future that she deserves without the muscle damage? Without being treated.
And I apologize, it didn't catch. She has hypo.
So we do have patients that either can't take acetazolamide or react badly to it. And as I say, was surprised to find that this probably makes up 25% of patients. This is what we're interested in developing treatment for. And there are treatments that we've used in patients, and we've reported the results in patients we've been able to figure out the combination. So far, I think we have been able to figure out the combination of what it takes to treat patients, but we really are in the process of working a big study of patients just like your 8-year-old daughter to make sure we have an understanding of, so we can talk about making her better for the next few months or few years, but we're really talking about the rest of her life, that we would like to find a treatment, show that it's safe, show that it's effective, and then move on from there in the patients that get some benefit but not enough to get another treatment.
Yeah.
Oh.
So my question relates to diet. I think especially with respect to hyper, when you talked about how there's fluctuations and one moment you might have low potassium, the next minute you might have high potassium. Are there specific foods that you should specifically avoid? I know you mentioned orange juice, but I guess given the change and it's not an obvious like you're too much or too little potassium, how should you focus your diet?
That's a good question.
Trial and error often is the best approach. because I've been impressed that one patient will get better with orange juice and another gets worse. The orange juice is complicated. It lowers the potassium, and yet it has a lot of potassium in it. The total body potassium of patients with periodic paralysis, all of it, is low. So in fact, we need to supplement potassium in all patients, but you can't give potassium in large doses to hyper, or it makes them weaker. Still, they need potassium, so it's a very complicated issue. So we're trying to figure out medications that are safe and effective. Diet remains something that does need careful study, but it seems to me to be somewhat idiosyncratic. One patient perhaps a bit different from another. That's not surprising. So I think the best approach is to keep a diary of what you take and try to experiment on yourself in terms of diet. The problem is people tend to have pizza, orange juice, and beer, and then blame the pizza or the orange juice or the beer. You know, it's often complicated by the fact that people are impatient and want to try multiple
Orange
things at
juice
once.
and beer?
That's what people say. Well,
After a marathon.
And I guess the second part of that would be just, given that you're saying there's fluctuations, is there any way to know when, if you're hyper and you have an attack, whether it's being precipitated because you're low in potassium at the moment and so you need potassium, or you're high in potassium at the moment and you should not? I mean, I guess.
Yeah, I think that's very tricky. I mean, that's super tricky for a number of reasons. But I don't know that there's any great way to do that. And ideally, we have various meters. We have this Cardi meter that's not FDA approved that I personally don't advocate using, but there are a lot of people who swear by it and they get it to work, and that's great. And there's another thing called the iStat, which is only used in hospitals, that you take blood and you drop it on the thing, and 2 minutes later you get a potassium reading. They cost like $5 or $10 a pop. I would love to be able to get Abbott to make those for home use. I mean, that would simplify this particular issue. And that's something that I haven't figured out how to do. If anyone has an idea of how to approach that, if they have any special expertise in that area, it would be great to speak about it.
I wanted to expand on the point about orange juice just to make sure everybody's clear on this. When it was mentioned before that orange juice, be careful about orange juice, it was not to say that there's something particularly bad about orange juice. It's just that everybody knows that orange juice has a lot of potassium in it, so it will often be recommended as a good source of potassium, but you have to realize that it is a mixture of, I'm simplifying, but it's a mixture of potassium and of sugar, and so the potassium raises your potassium, the sugar lowers your potassium, so it's kind of hard to predict, so you shouldn't use it as a treatment in the sense that it will have opposing effects and it's hard to predict what it's going to do. And to generalize the point, there's similar issues with a banana. Banana has a lot of potassium, but it has a lot of carbohydrate. And I was startled one day to walk into a supermarket and see every bag of potatoes from every brand that came in bags at least had a label on it that said a great source of dietary potassium. And it is a high source of dietary potassium, but it's not a great source because it also has a humongous amount of carbohydrate. And I actually mentioned this to the head of the FDA because I felt that this was a misleading claim that could cause problems. And she said she wasn't aware of that, but is going to have the appropriate people look into it. And so this is a general issue that's going to affect be careful not just about using orange juice therapeutically, but be careful about bananas, be careful about potassium, and think of them to some degree as a short-acting decrease because of the carbohydrate, but a long-term replenishment. And it's not the ideal, none of them are ideal ways to tank up on potassium.
I guess I'm next. Got a question for you guys, because with the paralysis I've got, and I'm not sure if it's hyper or hypo, my father actually has restless leg syndrome, and I have something similar to that. I feel like I get the ants from my legs, but then on top of that, I have what's considered to be ADHD. So it's like my energy levels are through the roof, and I constantly hurt when I pain. The problem I got is none of the doctors tell me that if I get teeth pain medication, it's not going to do anything. I didn't know if you guys ever encountered something similar to like that or heard anything, because it just, I'm always in aches and pain because my energy level is through the roof sometimes, because I'm not able to take much of the ADHD medication because it counteracts with my with the disease, but yet then I'm also in constant pain. So it's like I don't know what to do from there. I'm a basket case, I know.
Wow. Yeah, again, not to fall back on it's hard to take a history and give you specific personal advice in this kind of a setting. I don't know that there's really a right answer for any particular person as such.
That's what the doctor told me, and you know, every time I keep asking the doctor, he just gives me this puzzled look, scratches his head, and goes, I don't know.
But it's worth trials on guys.
Like, you see those local devices and all that don't work for me because they actually will shoot my eardrum through the roof even more, and they actually cause problems with my core. Lithium may be worse than actually paralysis, and then it shot my anger and the energy through the roof too.
So let me just say, one of my rules is one disease per customer. So I don't mean to be facetious. What I mean to say is that if I can relate all symptoms to a single disease, I try to do that. And so one of the things I haven't mentioned yet, but that I am particularly keen on, although we're doing this big multi-center trial with placebo in periodic paralysis, I'm very big on what are called N of 1 trials, and I'm actually doing them where you take, because if you think about it, a trial in 140 periodic paralysis patients is of great interest to everybody in the room, but it may not benefit everybody in the room because many of you don't get better with the treatment we're studying. So one really needs to do placebo-controlled trials in each patient with a variety of medicines. And we've set out, and I've done that over my entire career, because if you're going to go on medication, you want to be sure that it's working. And so we have done trials where we start the medicine, start the placebo, start the medicine, start the placebo, where neither the patient nor the doctor knows. So this is a placebo-controlled trial in a single patient. Where somebody has a complex situation like this, I've been willing to embark on a series of studies to try to control the symptoms. It's fairly expensive because you got to get a pharmacist to do all of this, labor intensive, but it sometimes gives you the answer that we're trying to get otherwise.
Okay, go ahead.
I catch some of the things you said at the beginning, including the name of the diagnosis you said you have, which sort of always startles me a bit because I run a database with 2,700 rare neurological diseases, and so if I haven't heard of something, I think this must be really rare, or maybe I just misheard it. But there are also sensory abnormalities described there are channelopathies with sensory abnormalities. We see some of that with the overstimulation in this lidocaine insensitive variant. Classically, there are the SCN9A sodium channel has their described mutations which produce a pain syndrome. So the fact that you're having things like this, I would agree with Dr. Griggs that I would tend to focus first on the possibility that you have something that's tying all these together. It may be something we already know about, but it may be something we don't already know about. But pain phenomena with channelopathies is certainly very well described with the SCN9A mutations.
Can I ask a quick question? Because I don't know.
I'm sorry. I want to move on. So maybe we can.
I'd be glad to talk more and try to.
Medication-wise, what do you say to a doctor though? Because that's like what you're saying. What do you say to a doctor? Like, try something.
Well, what do you say when you want to try something?
Like he's saying that work with the doctor and pharmacist work together. How do I go about something like that? I'm trying to take the answer later on, I guess.
So this is a general question that a lot of us deal with. So how do you work with your doctor to get them to prescribe medicines and get them to speak with other doctors? And you hope that they just do that. And if they don't, you know, maybe you're not seeing the right doctor. But anyway, I just want to move on. Jim King, you asked a question that was important to me, and I asked you to ask it to the group. Do you remember?
No, I think the answer to that was the availability of the study man after the study.
I see. Okay, fine. Okay, good.
Thank you, guys. Sort of all you got.
A quick question, if you can hear me. Is there any one person or organization that is coordinating the research that relates to this condition? Or does everyone just function independently and we look and hope that some of these research projects going on will impact our condition? And if so, is there anything that we can go to on the computer and see what is being done in different areas and how it's being coordinated?
So I would say that the PPA website and Jake's service he's run has been really, really good about answering such questions. We do have a working group that are addressing first the treatment, making dichlorphenamide available, now looking for patients who are not improved by dichlorphenamide, working on the symptoms of Anderson-Tawil syndrome. So we're picking off the questions one at a time, but there are more questions than there are physicians. And so it's taking us, obviously, a certain amount of time to get to each of the questions, but go through Jake and he'll steer you to the people, he's steering people to us with questions. We have, as I showed you on the slide, a big group that are working together, meeting together every year, collaborating. These are physicians interested in periodic paralysis from all over the world that are collaborating.
Let's get someone from the middle of the room. Oh, or over there, on that side of the room. Excellent.
I have potassium sensitive periodic paralysis. I'm on a low potassium diet. I've been prescribed medication by another physician, prescribed physical exercise by another physician. And the problem I'm having is I'm working with a personal trainer. And while I'm exercising, I am incurring different type of periodic paralysis than I normally have. I'm concerned that I'm actually hitting low potassium. Is there anything that you'd recommend that I do to try and keep myself balanced while I'm exercising? Currently, we'll go in right before I do my exercise routine. I'll take like a half a banana, just because I know I'm going to be sweating profusely, etc. But suddenly I'll be in the middle of it with my trainer and I'll lose my arms or I'll lose my legs, and it feels completely different than normal.
Do you, I mean, I know it's a little impractical, but have you been able to like take your serum potassium at that moment?
No. Every time I've ever been in the middle of an attack in the hospital, my potassium's always been normal. And whenever it's been in one of these other states, well, not in the gym, but at other times when it's been a little bit, feels weird, they've been unable to draw blood. I mean, literally.
My question is, you know, how do you know that the episode during the workout is a low one?
I don't know. That's what I'm trying.
So I think that, I mean, this is very tricky for people, and I mean, I know how I'd manage it if I were a physician and had a patient, but I'm a dermatologist, but I'd give them a prescription. I'd give them a prescription for a blood draw, and we'd have to find some way to get that blood draw to happen. I know with me, when I get a hypo attack, I'm out of it for an hour, or 2 hours, or 3 hours if I don't medicate, so that there's time to take the blood, to call someone to get the blood taken and have it processed, and it's still going to be low. Some people, they have an attack, and by the time they can get to where they can get blood taken, they're kind of out of the attack, and that muddies the water. But if you can get your blood potassium so that you know where you're at, that would give a lot more guidance as to how to treat. Yeah.
What's up with the myoclonic jerky?
What's the deal with the myoclonic jerky? Anyone want to take that one? No? Yes, no? I don't know what the deal is with the myoclonic jerky. Bruce, do you think that that's an aspect of some types of periodic paralysis, for example, Anderson-Toohill, that
Can't say. It should not be part of the usual sodium or calcium channel periodic paralysis because these diseases, myoclonic jerks, are things that normal people have. They're falling asleep, occasionally they will jerk. Some people, it's a really big problem. But we know that the genes for hypocalemic and hypercalemic periodic paralysis are not expressed in the peripheral nerve, not expressed in the brain. So it's unlikely that they're a cause of myoclonic jerks. Myoclonic jerks are very commonly in normal people and even more frequently in some fairly common
Every morning for 2 to 5 hours. Is there any advice what to do, changing drugs or so, to improve that?
again, this is kind of one of those patient-specific questions. I think, though, that we all can learn something from the patient-specific questions in terms of general principles. Which medications are those that are maxed out and at what doses?
Triamterene.
Triamterene.
And Diamox.
Diamox.
And the potassium chloride.
And potassium chloride. So what I would say in general is that patients, if they fail with a diuretic of one mechanism of action, sometimes they do better with a diuretic of another mechanism of action. Sometimes you can go with monotherapy, and sometimes you can go by adding in another drug. So if you think about the different drugs that are available, aldactone, probably not the best for a guy, but eplerenone, acetazolamide, dichlorphenamide, which if you can get your hands on, great, triamterene, and amiloride, you can imagine a few different combinations of things that may work. And again, I think some of it's going to be trial and error. Unfortunately, we don't have that, gene R672, S responds to acetazolamide, but gene R whatever responds to aldactone. It's not as easy as that. I don't know if any of you guys have other suggestions.
Just I would say that it's really, really important that you figure out what to do. Because I think if somebody continues having attacks, it's not a good thing. So there are a number of medications that need to be tried, and this is a situation where I continue to want to try additional things to improve.
And just one other little comment. Sometimes when I hear the comment from patients that they're maxed out on a medication, they're maxed out on the prescribing physician's anxiety level. They won't give more than this amount, period, at the end. And it's not maxed out because of the effect on the patient or side effects that they might be experiencing. So, the word, what does maxed out mean, comes into play.
I have a question concerning cognitive impairment, and I think from Lister I get the sense that quite a few people experience it, and I understand it could be a side effect of the Diamox, but I find after a bunch of severe attacks that I get a lot more brain fog, memory problems, and during my attacks I'm quite cognitively impaired. Just wondering if you have any suggestions of how to deal with that, if there's anything you can do.
Well, one place to begin, sure, all of the things that you mentioned can contribute to the, so-called brain fog, but there's nothing protective about the periodic paralyses. You may have a sleep disorder, for instance, that may alter your cognitive abilities, and so sometimes something as simple as yet another test to document that there's yet another problem, but it guides you down a road for a different alternative additional treatment. And sometimes it's adjusting not so much the daily dose, but the timing of the doses of the medications. Taking the same daily dose and spreading it further apart. For instance, some people, if you're taking 250 milligrams of acetazolamide, sometimes just breaking it in half and taking it spread out, or even breaking it in quarters. It means living by the clock, or living by, when am I taking my next pill? But if it helps you to function in life better, that's what we have to do.
One last thing, And the other thing is that, the timing of the medication. First of all, when does the brain fog occur? Does it occur always right before an attack, always during or right after an attack? And is it coincident with, taking a medication that may be brain fog inducing, like a carbonic anhydrase inhibitor? So there, a careful diary may, not likely, but may work out a simple, yield a simple solution. Have we exhausted all the questions? We have like, probably like a couple more questions, and then I'd like to take a 5-minute break and move on.
Hi, the hypo symptoms. The problem I'm having is when I have actual full body weakness, my heart starts having chest pain, and they want me to go on CPAP for sleep apnea, but when I trial it, I get an attack because I'm fighting the machine to breathe. I'm using all these muscles that are already weak, and then I get the chest pain syndrome. And my doctors don't believe me. And my question is, this whole thing of, they say the heart can't be involved because the literature says it's only the long muscles. How do we get past this, that it affects the whole body?
Yeah, please. Here, wait 1 second, boss. I'll just jog over here.
So we're working on it because I'm giving a presentation on cardiac arrhythmia in the heart, in periodic paralysis. Especially now we just look at hypokalemic periodic paralysis patients. So once we get that published, obviously there's more to it and more, everyone will know that probably you can't just easily say, well, it's periodic paralysis, the heart is not at fault. We just don't know it, and I will show some of these results that also make clear that it's very easy to say it's just only a skeletal muscle, but in my opinion, it's probably not.
Okay, actually, with that, I will let Vas have the final word here. I apologize. I just wanted to thank all of the doctors here for their time and expertise.